There's abdominal pain, and then there's abdominal pain. A common complaint. In fact, one of the most common complaints we see in the emergency department. So common that there are many myths and legends out there about what is concerning and what's just a bellyache. Our biggest responsibility is sorting out the surgical cases from the non-surgical cases. Who needs an emergent intervention? Who needs watchful waiting? Not an easy question and not an easy answer. So, what do we need to know at the bedside to detect the life threats?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. There aren't many absolutes in medicine, but sometimes we just have to think simply and not talk ourselves out of investigating a potentially dangerous diagnosis. So, what I'm about to tell you is bold, but I would much rather we ratchet up our sensitivity to catastrophic surgical conditions and deal with any false positives than to miss a single devastating case. Here are 3 mantras of the pediatric abdomen. Green vomit is surgical. Vomiting and distention is surgical. Vomiting and shock is surgical. Keep these in mind as we go through an age-based timeline. The neonate, birth to 1 month. Neonates can be tricky. We can't assume that all vomit is just regurgitation. Take your time to find out as much as you can about the neonate. It shouldn't take too long. Find out about his mother's health and possible comorbidities, and whether he was term, premature, his mode of delivery, his hospital stay, or any complications. Neonates who end up needing emergent surgery are just born with something that's not compatible with a normal life. They are little ticking time bombs. We have to make a timely diagnosis and rapidly intervene in the neonatal period. Although, admittedly, these are all uncommon, let's focus on the conditions that we're more likely to see in the ED. Necrotizing enterocolitis, malrotation with volvulus, and Hirschsprung disease. The first potentially surgical diagnosis in the neonate is necrotizing enterocolitis. NEC typically presents in the first week of life. There are case reports, of course there are, of NEC out to 6 months of age in chronically ill children. But this is not the norm at all. It just illustrates how we can't be rigid about how we look at epidemiology of disease. NEC usually is something that happens to brand new bowel. Think about NEC especially in the NICU graduate. However, and this is the key point and where we come in as emergency physicians, up to 10% of all cases of necrotizing enterocolitis are in full-term children, which means this is one for you and me, my friend. We don't know exactly why children develop necrotizing enterocolitis, but we think it may have to do with an underdeveloped intestinal immune system and translocation of bacteria. There's a lot of bad luck mixed in there as well. Neonates will present with feeding intolerance, but also something else. abdominal distension. So, GI complaint in a baby with distension? Think surgical. You may see Pneumatosis intestinalis on abdominal X-ray, but this isn't required for the diagnosis. Air within the wall of the intestine is a microperforation. How do we manage NEC? We treat as sepsis. We give broad-spectrum antibiotics. We resuscitate. We decompress with a nasogastric tube. And most importantly, we speak with our surgical colleagues immediately. The baby may be managed conservatively in the NICU, but we need all options on the table from the beginning. Intestinal malrotation with volvulus. 80 to 100% of children with malrotation with volvulus will present with bilious vomiting in the first month of life. Think about malrotation, especially in the first week of life. Remember, green vomit is bad. Neonates with malrotation may actually look relatively well initially, then rapidly present in shock. Vomiting and shock, also pretty bad. A few myths to dispel. Vomiting with diarrhea? Oh, that has to be acute gastroenteritis. Here's the truth. Diarrhea can be present with malrotation. Don't be fooled. So, how do we make this diagnosis? Truthfully, just a history alone of bilious emesis is sufficient to involve the surgeons. After calling them, or maybe you have an in-between case in what appears to be a stable child, you can do an upper GI series to show you the classic corkscrew appearance of the twisted bowel in contrast. But don't wait for this if the child is sick. Another myth. Normal plain films should exclude the diagnosis. The truth. If you get any imaging, then abdominal films with contrast are necessary to see that corkscrew with malrotation. If you happen to get an ultrasound, maybe you were unsure of the cause, you can see an abnormal orientation or flow to the superior mesenteric artery and vein. They are literally twisted. The normal side-by-side orientation of artery and vein is switched because the mesentery is twisted. How do we manage these in the ED? Well, we don't. The child with malrotation and volvulus needs a surgeon now. Get IV access, resuscitate, and volume optimize the child. Decompress the gut with a nasogastric tube. Perfusion of the bowel wall itself is at risk, and distension makes the local perfusion worse. Drop that NG tube and get that baby some bright lights and cold steel. Hirschsprung disease. Do you ever get the feeling that your neural crest cells just never migrated properly? Okay, good. If that were the case, you would be born with an aganglionic colon. You would have a section of your colon that just would not participate in peristalsis. 80% of the time, it's the rectosigmoid colon. That means constipation. I mean real constipation, so bad that it can lead to perforation and sepsis. How do we diagnose Hirschsprung disease? Well, if you're lucky, you don't pass meconium in the first 48 hours, and you don't go home until it's fixed. In the ED, Hirschsprung will present as either a bowel obstruction, or, if it gets bad enough, enterocolitis. You can make the diagnosis with a simple contrast enema. Just a little pearl here. If you are giving the contrast or examining the buttocks or doing a rectal exam with your small finger, then may I suggest you stand to the side of the baby, not within firing range. Contents are under pressure. Beware of the toxic megacolon. Vomiting, distension, sepsis. This child may present with a history of vomiting and be in shock. Don't just assume it's volume depletion from the vomiting. Remember, vomiting and shock, it's surgical. Resuscitate, give IV antibiotics, place an NG tube, call the surgeons. Getting the hang of it now? If your patient is stable, he may just need a planned rectal biopsy for confirmation. Surgery can be staged. First, with an abdominal perineal pull-through with diverting colostomy, then subsequent anastomosis, or it can all be done in one procedure, depending on your patient's presentation and stability. All right, before we leave the neonatal range, I gotta tell you something. No, really, listen. It may not be surgical. Remember the classic fake-outs. Non-accidental trauma may present just like this, or a CNS space-occupying lesion. Sepsis is always a mimic here. Also, undiagnosed inborn errors of metabolism. Just think broadly, which includes surgical consultation as needed. The infant and toddler, 1 month to 2 years. Okay, if you've survived the neonatal period and you weren't a setup for abdominal disaster, then the surgical emergencies you can have in this age range are important to manage properly, but you typically have time to figure them out. The two main players for infants and toddlers are pyloric stenosis and intussusception. Pyloric stenosis happens when there's hypertrophy of your pyloric sphincter. It may be genetics or an environmental or medication exposure. It doesn't matter because the child is trying to eat, but the food just doesn't pass through the pylorus into the duodenum. That sphincter is just too bulky. These are your hungry, not so hippos. They want to eat all of the time, but they just can't keep anything down. Babies present in the first few weeks to months of life with a subacute history of poor feeding. They have poor weight gain. Remember, normal weight gain is 20 to 30 grams per day. Usually the vomiting is projectile. Now, that's not a word I would go throwing around. Ask about where the vomit lands. If it's on the parent's clothes, we're okay. If it hits the wall, well, maybe not so much. On ultrasound, you see pyloric stenosis. The number pi, 3.14, gives you the dimensions for the upper limit of normal. So a pylorus with a dimension of pi, 3 millimeters by 14 millimeters, is diagnostic of a hypertrophied pylorus. If you do an upper GI contrast series, you will see the string sign, where the contrast barely trickles through the hypertrophied pylorus. Well, what do we do for pyloric stenosis? In the ED, the most important thing is to volume replete the child as needed and see what type of metabolic derangement he may have for us to correct slowly. The classic is all about the O's, the shape of the pyloric sphincter. Hypochloremic, hypokalemic, metabolic alkalosis. How is pyloric stenosis treated in-house? The inpatient team will talk with the parents about a trial of medical treatment with oral atropine via NG tube. The muscarinic effects of atropine decrease pyloric tone to buy the child time to grow out of it. This method was first popularized in Japan and has later been shown to be an alternative when surgery is contraindicated. But the most recent literature holds that surgical results are superior. In the US, often there is definitive treatment with the Ramstead pyloromyotomy. A myth about vomiting in this age is vomiting, it's probably just gastroesophageal reflux. Be careful here. GERD is not associated with poor weight gain or with electrolyte abnormalities. Another epic legend of a fail is missing the presentation of an adrenal crisis, especially in baby boys who may look phenotypically normal. Adrenal crisis, though, presents as shock, not as subacute poor feeding or malnutrition or dehydration. Intussusception. One of our favorite topics, right? 90% of intussusception is ileocolic, so the ileum telescopes into the ascending colon. The majority of cases have no pathologic lead point. Only 4% will have some underlying pathology that caused the intussusception, like a Meckel's diverticulum, a polyp, a Peyer's patch, or even Henoch-Schönlein purpura, which here is basically a spontaneous hematoma in the intestinal wall from the transient bleeding dialysis in HSP. We make the diagnosis of intussusception by ultrasound. Its sensitivity and specificity are near 100% in experienced hands. It's also not a bad idea to get an abdominal X-ray as an adjunct to ultrasound, because if there is already a perforation, then it's an immediate surgical case, and a positive plain film would stop you from doing the normal treatment. So what's that? It's an air or liquid enema. Both are diagnostic and potentially therapeutic. The hydrostatic enema uses either barium or a water-soluble contrast with fluoroscopy or agitated saline with ultrasound. An air contrast enema uses air or carbon dioxide with fluoroscopy or ultrasound. There is a slightly higher risk for perforation with the air contrast than with the hydrostatic contrast. It's a 1% risk. But if there is perforation from air, it's generally safer than perforation with a liquid. You should really get your surgeon on board. A brief phone call or a transfer plan if needed before you reduce. If there's a perforation, you want access to a surgeon immediately. Traditionally, these children are admitted for observation. Some hospitals have protocols for a brief observation period and a rapid discharge home. A myth about intussusception is that, again, vomiting and diarrhea is a clear-cut case of acute gastroenteritis. Not so fast there. This is simply GI upset, which can be a mimic, but more importantly, it's the child who returns to the ED after a previous visit with a diagnosis of AGE. Viral infections can stimulate Peyer's patches and cause a lead point. In other words, even the clear-cut case of AGE may be a prelude to intussusception. Vigilance and good precautionary advice are in order. Adenovirus and bacterial enteritis have the highest association with intussusception. Earlier forms of the rotavirus vaccine, called RotaShield, conveyed higher risk in the first few weeks immediately after vaccination. Luckily for us now, the current iterations of the rotavirus vaccine, the RV5, RV1, luckily don't carry the same association with intussusception. Remember, with infants and toddlers, we still have to be careful and meticulous with knowing when to investigate, but luckily, what ails them, we usually have time to figure out. the young child and older, 2 years and up. This kid is getting more talkative now, and you may get some more helpful clues in your interaction or your history. 2 conditions that start to become problematic in this age are appendicitis and bowel obstruction. Appendicitis occurs in all ages, but it's rarer in infants. Infants don't usually have a fecalith. Rather, they have some other anatomic or congenital condition that causes an abnormally shaped appendix. Appendicitis is more common in school-age children and adolescents. The biggest take-home is that younger children present atypically, and they're more likely to have perforated when the diagnosis is made. The perforation rate in infants is 80%. Children less than 5, 50%. School-age children have a perforation rate of 30%, and adolescents will present perforated 20% of the time. Just be wary that we may already be behind when we start the workup. Children often have nonspecific signs and symptoms with appendicitis. Hopefully, they'll have some abdominal pain first, with vomiting to follow, just to help us key in on the diagnosis. The location and orientation of the appendix also varies. The appendicitis scores will also vary in their performance. This is where having a low threshold for investigation and using your clinical judgment will help us. Having said all that, the biggest pearl I can offer today is this: respect fever with abdominal pain. The presence of fever triples the likelihood of appendicitis. The positive likelihood ratio is 3.4. And here's a nice mirror image. The absence of fever markedly decreases the likelihood of appendicitis. The negative likelihood ratio is 0.3. Remember, likelihood ratios are on a logarithmic scale. If you can, try to start with an ultrasound. You may find dilation of the appendix. You might find wall hyperemia, non-compressibility, or even free fluid, signaling perforation. Serial exams are your best friend here. Okay, so what do we do with appendicitis? Well, what do you mean? We need to get it out, right? Well, right, except there are current trials ongoing now for the identification of low-risk children and adults who may benefit from a trial of antibiotics. Of course, if the child is perforated, some intervention will be needed at some point. Sometimes an interval appendectomy is planned. IV antibiotics are given via PICC line for 4 to 6 weeks to cool off the belly and promote a nice rind around the abscess, and then surgery is done to remove. Obstruction. Obstruction is not very common, but when it does happen in children, it's usually from the same culprits as we have in adults. The ABCs: adhesions, bulges, so hernias, and cancer. One addition I'd like to make to that is with severe acute gastroenteritis. Sometimes children will get an ileus or even an obstruction. So I know I've been going on and on about surgical, but sometimes it's just not. How do we make the diagnosis? Remember, obstruction is a sign of another condition. Look for the cause of the obstruction, surgical versus medical. You can perform an abdominal X-ray if your pretest probability is low. To be frank with you, though, for good or for bad, we often go to CT of the abdomen and pelvis for moderate to high-risk presentations. It helps to confirm, and it also helps for possible surgical planning. It's better to get a CT and rule out the disease than just to go straight to laparotomy with the good intention of saving the child some radiation exposure. One CT of the abdomen and pelvis carries a small theoretical risk of cancer years later. However, an unnecessary surgical exposure presents a very real risk now, and since the peritoneum has been violated, a real risk of lifelong complications of adhesions and more obstructions. So, you've made the preliminary finding of obstruction. What do we do now? Remember, deal with the underlying cause. And the rest is surgical magic. You know the formula. The surgical incantation, NG tube to low intermittent wall suction, NPO, fluid management, admission, and serial examinations. Okay, I know I've said NG tube umpteen times here. It's not to be taken lightly. It's ranked in adults as one of the most painful procedures we do to awake patients. Here are some tips and tricks to be a good human being when it comes to NG tube insertion. Nebulize 4 milligrams per kilogram of 4% lidocaine by face mask to pre-treat the nasal, oral, and pharyngeal mucosa. Use lidocaine jelly as a lubricant. Have all of your supplies ready, including hydrocolloid dressing, so for example, Duoderm, transparent film dressing, so for example, Tegaderm, tube, tape, syringe, and an oral sucrose solution. You can also take the distal end of the NG tube and find an appropriate sized oral pharyngeal airway and put the NG tube along that groove. Put the whole contraption in ice water for about 2 minutes. And when you take it out, the distal portion of the NG tube has taken on the form of the oral pharyngeal tube. It makes it for much easier passage. Wrap the child and gently restrain him. Give anxiolysis as appropriate. Place the Duoderm on his cheek near his nostril. Measure the insertion depth, so the tip should be past the xiphoid and run along the midline and loop around the nasopharynx. Mark that depth. Hold the tube by the distal end and suspend in the air to see what the natural curve is to assist in its direction. Insert gently in a stepwise fashion, giving the kid a break here and there. Give oral sucrose solution or cold water in between pauses. If you try to forcefully insert the tube, it may cause spasm and poor direction of the tube, as well as just the terrible discomfort. Watch for cough, for difficulty breathing, or any discomfort when you're not manipulating the tube. This may be a marker that it's in the wrong place. Insert to the mark at the nostril and secure the tube over the Duoderm and cover with Tegaderm. Affix all of that with tape. Verify placement with an air bolus and chest x-ray. Set that to low intermittent wall suction. Remember, in awake, non-intubated patients, there is usually time to plan and just be a good human being. When it comes to surgical abdominal emergencies in children, take these pearls home. Consider surgical pathology early in the encounter. Resuscitate while you investigate. Green vomit, surgical. Vomit and distension, surgical. Vomit and shock, surgical. Have a low threshold for imaging and consultation, especially in preverbal children. Follow these guidelines and just be your normal, careful self, and it'll be just fine. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.